Having me. We're super excited to get this kicked off for real. I think you guys have probably been hearing from some of your colleagues that were maybe in the pilot sites that, we're working on remote monitoring. And I think Ballard actually probably has a really good population, a lot of people who are kind of more digitally inclined than maybe the general populace. Potentially some patients who are getting newly diagnosed with type 2 diabetes, and this might be a good modality for them, especially for lifestyle change, et cetera. So excited to roll this out at Ballard. Just to introduce me and Mika, I think you guys know me, but let me introduce myself. My name is Crystal Wong. I'm a family medicine doctor. I practice at Ravenna. I used to be your AMD. And now I'm focused predominantly on digital health. I do have a small practice at Ravenna still. And then Mika, you want to introduce yourself?
Thank you, Dr. Wong. Yes, my name is Mika Mäkinen, and I'm a project manager for the telemedicine team. And I used to be a clinic manager at the Smoky Point, so it's my pleasure to be here.
Yeah, and so Mika and I will be here, to help support the rollout, and if you guys have questions or whatnot. We also have some other key members of the team, such as Ellen Kahn, who I think you guys might know. She's one of the assistant directors for UWPC, and she is kind of partnering with me for digital health rollouts and responsibilities for primary care. Additionally, Tammy Wilson and Allison Everett have been very, very intimately involved in the rollout of this program and can answer any questions you have, around the partnership with your RNs and RDs in this program, because it really is collaborative. All right, so why don't we jump right in. So what is remote patient monitoring? I think you guys know this already, but and I think you guys maybe have been doing this informally for years, because patients use all sorts of devices to send you all sorts of interesting information, most of it unsolicited. But it's basically use of a device to send some sort of patient biometric data from home to the care team, and you being able to take care of them based on that data. The market is really shifting to this, and there are a lot of chronic diseases where RPM is becoming standard of care. Remote patient monitoring is standard of care for type 1 diabetes who use an insulin pump. And a lot of the pumps actually come integrated with a CGM monitor. So it's a little bit newer use in type 2 diabetes, which is what we're going to talk about today. But there's a large body of evidence showing that patients get better outcomes, decreased A1C in use of CGM, but also more engagement in their care. And I think that's one of the things that us as primary care doctors always kind of struggle with is, patient engagement with their care, because you just have this really limited glimpse into their life, here in the office, whereas, they go home and all their typical social determinants of health kick in. So this is one way to actually bring medical care to the patient's natural environment. So these are the program components that we're going to go through today. So we'll talk about the workflow, we'll talk about identifying patients, enrolling them. We'll talk some about the nuts and bolts of the data submission and upload. We'll talk about interpretation, and we'll talk about coding and billing. And please do, jump in if you have questions. Mika will also be watching the chat, and we can always pause and clarify things. Okay, so I'm not going to go through this slide in super duper detail, but this is a Visio document that really shows the whole workflow of CGM RPM from nose to tail. So for those of you guys who are kind of into this, this might be a good tool for you if you just want to kind of map out the whole process. Again, this is a very team-based program, and you can see basically every team member in your clinic is going to be involved in some way, shape, or form. So this document is divided into what we call swim lanes. So at the top in the yellow, there's what the clinical staff would be doing, so the MA, RN, and RD. There's the patient responsibility, there's the provider workflow, there's the panel navigator, and then at the bottom we actually have like a little kind of boxes that show where CPT codes can be dropped for the services. So, I think you guys know we ran a pilot of this at Ravenna, Issaquah, and Woodinville, and we learned a lot. First of all, it was very clinically successful. In fact, 100% of the patients who enrolled in the CGM pilot achieved their GMI goal. We also learned some good lessons on where we could, improve our workflows and improve our education, et cetera. And one of the areas that we really put a lot of work on, as you can see my cursor, is right here, and that is getting the patient their equipment and getting coverage for equipment, especially for Medicare and Medicaid. I'm actually going to spend quite a bit of time in this presentation just kind of walking you through that part of the workflow from the provider perspective, because that can be confusing, I think, for you and the patient, and frustrating for the care team. Okay, so first of all, let's identify who would be a good fit. And I think this is really, really key. This is actually an area where we had a lot of really good discussion at the wrap up of the pilot. And it's really, really important to choose the right patient for this program. Because, as we know, certain patients, certain modalities work better than others, right? I mean, that's why we have these personalized agenda setting, et cetera. So who is included, who is eligible for this program? And let me draw a clear distinction between someone who is eligible for this program and someone who's going to get insurance coverage for their equipment, okay? In the next few slides, we're going to talk about insurance coverage, but this is really just about medical characteristics that would make you eligible for this program. Okay, so first of all, we're focusing on type 2 diabetes. You can see below there's exclusion criteria, and type 1 diabetes is, those patients are not included in this program. I know all of us take care of patients with type 1 diabetes, especially those who maybe don't want to see an endocrinologist for some reason, but they would not be for this regimented program. Then after you kind of have the criteria, if they have type 2 diabetes, the rest of them are really and or. You only need one of the below criteria. So maybe the traditional patient that comes to mind for something like CGM would be someone who's on insulin. So that's great. That would be a great fit for this program if you've got a type 2 diabetic on insulin and you're trying to manage, dosing adjustments, et cetera. They don't have to be on insulin though. They could just be someone who has difficulty with glucose management. This is a great fit for that patient that you've been trying to get to do their chem sticks reliably over years and years and years and haven't been able to because they just have this barrier to poking their finger. It may be someone who has a lot of hypoglycemia and you just want to, trend their blood sugars a little bit more real time. Additionally, this is a great fit for patients who want to tailor lifestyle. We're going to talk a little bit about the reports that come out from the monitor in a little bit, but I was in the pilot site, and so I enrolled some patients who were newly diagnosed with type 2 diabetes. A couple of them absolutely did not want to take any medicines unless I forced them to. And so we did CGM so they could see, their curve and titrate their diet. They could increase their exercise and see what that did to their overall glycemic control, et cetera. So this is actually quite useful for lifestyle modification. Okay, so people who are excluded, so anyone receiving care from an endocrinologist, so even if you have type 2 diabetes and you're seeing an endocrinologist, we would not enroll you. If the patient is interested and they see endocrine, they should talk to endocrinology. I know the DCC is doing tons of CGM. I've seen their reimbursement reports. They're billing out something like $200,000 a month in CGM bills. So I know they're using it a lot. This is not for pediatric patients. This is not for gestational diabetes, and as I mentioned before, this is not for type 1 diabetes. Now, there are use cases in all of those populations. In fact, there's a growing body of evidence, but just for our internal program, our nurses, our RDs supporting these patients, we're not including these patients. Some other places to catch patients or mine for patients that might be good fits. So obviously, I think all of you guys have some complex patients who are enrolled in care management. You're already working very closely with your nurse. So, if they have diabetes care gaps, they might be a good fit. Additionally, maybe you actually have a patient who has been difficult to engage and, they're only showing up when you run your panel management lists of patients with diabetes who are not meeting the A1C goal. So you might actually want to identify that in one of your care management meetings and talk about this with your panel navigator. Before I jump into insurance, any questions about medical eligibility? All right. Okay, so now let's get complicated and into territory where none of us particularly enjoy this. If you do enjoy it, maybe you should go work for an insurance company. So insurance coverage for CGM equipment. So this is obviously in flux. In fact, every year it's been getting better and less restrictive, but it still is, not just globally covered. So for commercial insurance, typically anyone with a diagnosis of diabetes, you can see this in this grid right here. Any diagnosis of diabetes, doesn't matter if you're on meds, doesn't matter if your A1C is controlled, doesn't matter if you're on insulin, can get coverage for their equipment. Now, obviously, there's some patients that are on high deductible plans or whatnot, and they might have to pay out of pocket until they hit that deductible. We can't really speak to that. But in general, in terms of just approval or denial, coverage or no coverage, commercial insurance will cover it with any diagnosis of diabetes. For Medicare, you need these three criteria. You need the diagnosis of diabetes, you need to be using insulin at least TID, and you need, quote unquote, frequent insulin adjustments. So there actually is some language in the Epic tools, the smart text that we constructed for this program, that actually have language that covers this, so that when we're trying to get insurance to pay for the equipment, your documentation will support the medical necessity. I think Medicaid honestly is the trickiest because you need the diagnosis of diabetes, TID, or at least TID insulin, frequent insulin adjustments, and self-monitoring of ChemSticks at least QID. So again, this is in the smart tech language. It is confusing. We're trying to simplify it as best possible, but it is what it is. Hopefully this coverage gets better as time goes on. Now, just because the insurance isn't going to cover it, and as long as you meet the medical eligibility, so let's say you have a Medicaid patient who just got diagnosed with type 2 diabetes, is not on insulin, is obviously doesn't need these last two boxes, but really it feels like this could be impactful for their health, you can still enroll them. We just need to figure out how to get them equipment. And there are a couple of tricks. One is Libre often has coupons. I know I have one patient who we did kind of off-label use for impaired glucose tolerance, and she wanted to do this, and she got a coupon from Libre that brought the cost down for the sensors. Just FYI, the cash price for 2 sensors, and each sensor lasts 14 days. So, a 1-month prescription would be 2 total sensors, is $70. So $70 cash for 2 sensors. So you might have some patients that have the means who are willing to pay cash. There are often coupons through the Libre website or through GoodRx. You could also ask the pharmacist to run the sensor through GoodRx as the benefits, as opposed to running their own benefits, to see if the cash price is affordable through that. But also FYI, the RPM codes have been really well covered by all payers for any diagnosis. And the reason why we know this is because we did a hypertension RPM pilot and we got no denials. Medicaid, Medicare, commercial, Apple Health, Molina, all of them were paying for the RPM code. So really, if you have someone who meets eligibility, maybe we can figure out a way to get them equipment, even if their insurance wouldn't necessarily cover it, and still do the RPM program, because the RPM codes are very, very well covered, kind of agnostic of diagnosis. So let's talk through kind of some steps, and then we'll kind of circle back to insurance, because when the provider has to order the equipment, that's where, you have to kind of finesse it a little bit. So you're gonna figure out who would be a good fit, whether that's through your panel navigator, through a care management meeting, or through you just kind of continuing to work with your patient panel and identifying patients who have newly diagnosed diabetes, or ones that you're managing that you think would benefit. We have a consent phrase, and we kept this very generic because we're assuming with the way things are moving in healthcare, that we will be doing RPM for other types of medical conditions too. So it's just a straight up RPM consent. There's a little wild card in there that you need to put what type of RPM. So you would just type in, CGM in there, and that kind of covers the consent language. You can do consent in obviously a face-to-face visit, telemedicine visit, phone visit. You can also do it during a phone call as long as you document it, or even through MyChart messages, the back and forth of consent, like, similar to, I think, probably what you guys are doing for e-consults, since we're required to consent for e-consults. I know I often do MyChart consent for e-consults. And then you'll place a referral to RPM. This is another step that compliance wanted us to do to verify that the primary care provider is referring a patient to a specialty program. It's considered a specialty program. And so you put in the referral to RPM. And then there's a dot phrase that has all of your medical necessity documentation, as well as some care planning. So it's also very helpful for communicating to your nurse or RD, what the goals are for this patient, the med changes, that type of stuff. But it also has all the language about, the patient is using insulin this much, it's medically necessary that they enroll into this program, yada, yada, all the stuff that later you'll see the prior auth team may need that documentation in order to get it covered for the patient. So this way, when you order it for your Medicaid or Medicare patient, it needs to go through the PA process. The team can just print your note and it will have all the language in it, as opposed to them having to message you and be like, Dr. Wong, you need to write in your note that it's medically necessary for them to do CGM, and then I can submit the note. So this will just kind of cut to the chase. And then make sure you CC your chart to, actually, we got a good suggestion from Tammy and Allison to just CC it to your RN and RD. Because I think depending on the clinic, there's going to be variable support for this. It may be the RN doing the teaching outreach, and it may be the RD. So I think to cover all bases, it's best if you can just, send it to both parts of your team, and then they will figure out who's going to do the intake, et cetera. Okay, so in that visit, or, if you consented them through MyChart or whatever, in that encounter, you are going to order them their equipment. And ordering their equipment is, a little bit awkward when you first start doing it. So for commercial insurance and Medicaid, you're ordering it just like a medication. And actually on the next slide, I have the order, so you can take a look at that screenshot. So it's just like ordering the metformin that you were going to start this patient on anyways. You order the Libre 2, and you have to figure out whether the patient has a smartphone or not. If they don't have a smartphone, you have to order them a reader. If they have a smartphone, then that's great. They just download this app on their smartphone and they use their phone to sync to their sensor. If they don't have a smartphone, they have to get this kind of reader that would take the place of a smartphone. So if they don't have a smartphone, you have to put in 2 prescriptions. If it's Medicare, the Medicare benefit goes through DME. So it would be just like you're trying to get them TED hose. And there are a couple of ways you could do that. You could do the referral to DME, and then you could just type in, Libre 2 sensors, dispense 2, refill, whatever. And, that would print, and you sign it, give it to the patient, tell them to give it to, some sort of medical supply company. Or you can actually use the medication order. You would just have to default it to print instead of, ERX. And then, you would pull it from the printer, sign it, give that to the patient, and the patient would have to take that to a medical supply company. Then what happens for Medicaid is what would happen, like just getting covered for any sort of medication. The patient would go to the pharmacy, try to pick it up, the pharmacist probably will tell them a PA is needed, and then they would trigger the PA process that goes to the PA team that we have that already does our prior auth, and then they'll pull together the necessary information. If it's a Medicare, in addition to giving them the actual prescription or DME form, whichever way you decide to do it, to give to the DME company, there's actually a CGM DME form. And you'll see that link right there in the PowerPoint slide, but this is actually also linked in the smart text in the vanishing tip. So you guys could also just click it out of the dot phrase. It's also housed on the UWNC internet site. In fact, that's where the link in Epic links to. And then you have to fill out this DME form stating that there's medical necessity. And so that needs to kind of get packaged up and sent to Medicare in order for them to cover CGM. So as you can imagine, this was a little bit tricky to figure out. And this is why we put a bunch of work on this after the pilot, because our pilot clinics really had to figure this out themselves. So if you're interested, it's not in this slide deck, but we actually have a video similar to the one that we showed you just for the overview workflow on just this part of the workflow. So for those of you who are interested in the sausage making. But we did kind of shore up the team that would help support this part, because we know that this is confusing. This is what the Epic order looks like for the Libre 2, and you can see it's very small. But this one in the upper left says Freestyle Libre 2 Reader, so that's the device. And the spotted one says Freestyle Libre 2 Sensor. And if you're just sending in 1 month, you would just put 2 sensors with however many refills. If you have a patient who wants to do this longer term, you could give them 6, and that would be a 90-day supply. This is just what we just talked about in words. But essentially what your RN and RD will be doing is, number one, they'll be looking out for the referral to RPM. That actually drops into the care management work queue, which the RNs already work. And then your RN is going to take a look at your documentation and make sure that they have everything that they need, namely that you order the equipment. Now, we always we can mess up sometimes or forget, or you're in the midst of a busy clinic, et cetera. If you didn't remember to put in the orders, they're going to pen the orders for you and send it back to you, and then you can co-sign it. Then once all the boxes are checked, they're good to go, the RN or RD is going to call the patient and see if they're ready to schedule an intake. And this is actually a good stopgap for those who maybe have Medicare or Medicaid, because if they've been having problems getting it covered, then the RN and RD will identify that, and they can kind of help figure out where they are in the process of the prior authorization. Then once the patient has all their stuff, including their equipment in hand, the RN and RD will schedule their intake appointment. I'm not going to go through that slide because we just talked about it. So the intro meeting with the RN or RD is twofold. Predominantly it's for actually training the patient on how to use their sensor and their device. So they'll actually practice with the RN and RD, putting a sensor on their arm and then syncing their device to the sensor and pulling some real readings. If there's still time left, or the RN RD was able to book a longer appointment, there's actually some history taking, lifestyle coaching that they can also do. They can also split it into 2 visits if they like, but the main focus of this meeting is going to be making sure the patient is comfortable with their equipment. And just to let you guys know, if you want to see the equipment, all of your clinics actually have some sample equipment that was delivered by Mika from the Libre rep. And so all of you guys should have some in your clinic if you've never seen one of these before. I just want to also call out, just as a favor to your friendly neighborhood RN and RD, please just make sure that the care plan is continuously CC'd to them, because they're going to be doing a lot of your in-between care, checking in on the patient, et cetera. And we just want to make sure that they have all they need in terms of your specific diabetes plan for the patient, so that they can reinforce it. Excuse me. They can check in on changes, et cetera. So the patient has been enrolled, they had their class, and this is the expectations for the data submission. So these sensors, you actually wear them continuously 2 weeks at a time. And when the 2 weeks comes to an end, you change it and you put on a new one. The patient is supposed to be syncing their device at least every 8 hours. That's as much memory as that sensor will hold at one time. So if they forget to do it, you're just going to get a blank. And I'll show you this in the AGP report. But this is the standard that the RNs and RDs are going to be training to. Then at the determined amount of time, which is probably going to be at minimum 14 days, potentially 30 days, the RN will log into LibreView, and actually every single one of your clinics has a LibreView account that the nurse is going to create. And then they're going to input the LibreView data into Epic. And this is going to show up in a couple ways. One, you're going to get a CC chart that has a standard dot phrase from the RN that actually has a snapshot of the key metrics pulled from the AGP report. I'll show you this in a second. In there, so you can just kind of look at that encounter and get an idea of how well your patient's glycemic control was. It'll also have a link in the CC chart, so you can actually pull the whole AGP report if you want to look at the PDF of it. And then the RN/RD will actually input the key metrics into a diabetes flow sheet, which I'll show you at the next slide. That way you can actually trend the data. So let's say this is your third AGP report, and all of this has been input. You can see in the diabetes flow sheet, January GMI was 7.5, February GMI was 7.1, and March was 6.9. Like, you'll be able to see it all together in the flow sheet. So you don't have to go back and forth into like the media tab, which all of us hate doing. And then just know, like, if there's any communication, that just make sure you kind of route it back to your RN/RD as you do, for other types of care that they're supporting for you. This is what the flow sheet looks like. And hopefully you guys all use the flow sheet tabs. I mean, we have to use it for like Medicare wellnesses anyways. But if you see this little search thing here, you would just type in diabetes and a bunch will pop up. And this is the diabetes MA note. It's kind of a weird name, but that was in Epic. And what you'll be looking at is these ones that are highlighted here, the GMI, the time in range, and the time below range. And we'll talk a little bit more about those in the upcoming slides. There's something in the chat. Look at this.
Yeah, there is just a note from Alison Everett that we got in the Libres. If providers want to practice and test them at the clinic, feel free to do that. Cool.
Great. All right, so let's dive into what the heck an AGP report is. And I actually have some resources at the end of this deck too, for those who want like a little bit more in-depth training or want some real life examples. There's actually a really good presentation that Dr. Savitha Subramanian put on for the pilot providers, where she goes through how to interpret this. It's an hour long, so you have to carve out some time. There's also a really nice video from Abbott that goes through the nuts and bolts. I think it's like 13 minutes and 46 seconds long, Elson. I watched it the other day. And it went through really, everything you need to know to go through these reports. And there's actually a lot of resources on the Abbott site as well. And there's also a link to a very good document that's got a collection of review articles about CGM. And the evidence for using it. It's actually compiled by Dr. Earl Hirsch, who's one of the diabetologists here at UW. So that's all in the end of this deck. All right, so here's your tour of the AGP report. This is you get actually quite a bit of reports from LibreView, but this is the one that you're going to be using predominantly to act on. And so it's kind of divided into 3 areas. On the upper left, you have your key metrics. such as your GMI. We'll talk about specifically what the heck a GMI is in a little bit. And then it has this time in ranges, which is also very helpful. And at the bottom, it has this ambulatory glucose profile, which is kind of like an average glucose, depending on the individual days. And you can see the individual days down there with the little calendar boxes of, you know, the time of day and how high or low blood sugars are, or sorry, interstitial glucose is. And then the patient will have also kind of marked in using their app, like when they ate, when they exercised, et cetera. So, you know, you can kind of talk through different activities or interventions and see what the subsequent effect of the glucose was. They should also be marking down like when they take their meds, et cetera. So first, let's just start in the time in ranges. And you'll see that it's divided up into 5 colors. Predominantly, you're just going to be looking at this target range, globally lows, and globally highs. Time in range, meaning the green bar, glucose of 70 to 180, is actually one of these new core key metrics for helping manage diabetes. And the goal is greater than 70%. This corresponds to an A1C of 7%. I think per the Abbott video, it's something like for every 10% delta, it's like a 0.5 to 0.8 delta in A1C. So you can kind of go from there. So like if they're 50%, that would be like 8.6 or something. So anyway, so this is kind of helps you gauge global control in addition to looking at metric like A1C. Time below range would be anything below 70, and that would equate to your hypoglycemia. And then anything above 250, or sorry, above 180, they're counting as highs, okay? Then if you move over to the upper left-hand side of the report, you'll have your key metrics. And in the next slide, I have this kind of stepwise algorithm, or stepwise, I don't know, like stepwise plan on how to interpret AGPs. And one of the key things is whether or not there is enough data in this report that makes it a good enough snapshot of the patient's glycemic control for you to actually act on it and count it as valid. So right here, you're going to see how many days does this report encapsulate, and you want at least 14 days of data before saying that, you know, these are is enough time for me to accurately gauge, you know, how this patient was doing. So in this case right here, this is for 28 days. It's also going to give you how often the patient was scanning or continuously wearing. So this is this percentage, and you want at least 70% of the time. So of the 14 days that they're on it, at least 70% of the time they're reporting. And so this report, you can see right here, percent time at CGM is active. They're very good. It's 98%. I mentioned this before, but they have to sync it at least every 8 hours, otherwise they lose data. Then you're also going to have, you know, your average glucose right here. And then you're going to have your GMI, which is essentially a calculated A1C based on the glucose reported in this time frame. Okay, so this is just kind of nice because we know that real A1C is a long-term metric. It can take, you know, 90 days before any sort of change will really accurately be reflected in A1C. So this gives you a little bit of a you know, closer gauge of what your intervention actually is doing to long-term glycemic control. And then there's also glucose variability. There's a very statistical definition if you want to hear it from Abbott. I'm not going to try to relay it here, but basically you want to limit the variability, because then you will lessen the risk of hypoglycemia, which is you know, what we're always concerned about, especially when using insulin for diabetes. So you want to look in and see if the glucose variability is less than about 33%, and see in this case it's 25.5%. So this patient is actually doing pretty good. So here's your stepwise approach. Number one, you're going to say, okay, is this report valid? Is there enough data that I can actually make changes on it? A best practice in going through these reports, especially since one of the biggest benefits, aside from some slightly improved A1C control, is this engagement of the patient with their care. So it's really good to sit down with the patient, whether that's in person or virtually, and go through the report together. It's actually quite easy to do that through Zoom. If you're doing telemedicine, you just use the share screen and bring up the AGP report that's in the media tab and go through it. And then you're going to look at look at the key metrics, share that kind of global overview with the patient. And then you're going to kind of dig into their glucose curves, right? You're going to look at, similar to sitting down the old-fashioned way with a book of hand-scrawled chem sticks that hopefully the patient remembered to bring in. You're going to look at it and say, okay, when did you eat? When did you take your meds? Let's look at, where are your highs, where are your lows? Oh, we should, maybe you need more prandial insulin, or maybe you need more basal, or maybe this metformin is not cutting it. We need to add something else on. All of those things, maybe, 3 slices of pizza is too much, but if you eat 2, look, it's not so bad. Whatever it is, that's helping drive or helping you interpret these patterns. And then you're going to look, you're going to make an action plan with the patient, like, okay, actually let's increase your Lantus, a couple units and see, or, you're doing great. I think if you can exercise every single day, you see you have much more, or much less variability of much, less lows. So if you could just exercise every day, I think that we don't need to escalate your, medication plan, et cetera. And then we actually have a documentation note there, the CGM RPM interpretation note. And that, if you use that and fill out the criteria, it's a very simple dot phrase. You can then build a code for interpreting the AGP report. And actually later I have some billing tools for you guys to look at, because I know when you're learning how to build new codes, it's always kind of confusing. And then again, please CC the chart to your friendly neighborhood RN/RD. They're an essential part of this program. They need to know what changes you want to make.
Dr.
Yeah.
There is a note from Alison Everett in the chat, stating regarding a provider providing consent, it should be an interactive encounter, in-person telemedicine on the phone. So this way patient can ask questions.
Yeah, I mean, let me just say this too, Allison, because I have asked Ruth Perkins this like 5 times. You can consent through MyChart as long as it is interactively documented. And the example I've been giving providers is like with e-consults. Oftentimes I'll tell patients, we're going to order these blood tests. If they come back looking funky, I'd like to get a hematology e-consult. And then I'll get their results back and I'll send them a MyChart message and I'll say, hey, Sue, your white blood cell count still looks weird. Are you okay with me ordering the e-consult? And then I will wait to get the MyChart response and their patient will say yes, and then I will order it. So if you have that documented and you are the provider, obviously this is not for RNs or RDs to use, that counts from a compliance perspective as consent because it is documented and written in the EHR. So if you just, ordered it without documenting anything in the chart, you could be in trouble with compliance, but they consider that a interactive consent. Okay, so changes to care plan. So the RN is going to use predominantly, the RN/RD is going to use predominantly this dot phrase right here, and it's going to have, some information about, they can just use this if they're purely downloading and putting together, your data packet. It actually doesn't have to be a patient-facing or patient phone call or anything like that to get billed out for the time. So for instance, if your RD takes 25 minutes, getting stuff from LibreView, putting into Epic, et cetera, and they document that, they can actually bill out that time. That being said, we do think that there's going to be a lot of correspondence with the patient. And so, maybe your RM is checking in and seeing how the patient's doing on the new med, or maybe the patient wants to tell them why there's some aberrancy, like, oh, I went on vacation and I went off my normal diet, et cetera. That can all get documented there, and it will be CC'd to the PCP. For AGP report interpretation, we kind of went through this already, but there's the interpretation note, and then you can bill for the interpretation. This does not have to be in a visit. That being said, as I mentioned before, one of the biggest benefits of doing CGM is this discussion with the patient of engagement with their care. So, if you just interpreted it and, this is not in a patient-facing visit, you could still bill it, but it's probably not the best practice. And then there's this treatment ABS that can summarize care change recommendations, and both, the RNs, RDs, and providers can use that. So, if you're following up with a patient, you're going to titrate their metformin, you're going to increase it, you could use this and document the medication changes for the patient. And then, things will just kind of come through your in-basket as you're used to, sharing patients with the RN, RD. Here's a handy dandy billing guide. This might be one of the job aids you want to print and just have at your desk, especially as you're getting to know a new skill. You could also, make yourself some speed buttons. I know I'm a big fan of speed buttons. I have a whole bunch in my billing module. We have this job aid that's housed on the UW Telehealth Services SharePoint site. We'll make sure we get you guys all these links. And it has pretty much a comprehensive overview of the whole program from soup to nuts. There are maybe some sections that might be more helpful for you as a provider to print, such as the billing coding summary table, the smart text summary, et cetera, that you might want to just have handy. That being said, this whole job aid is only 8 pages, so it's not super duper long. Here's the additional resources I mentioned. So there's the link to Dr. Subramanian's CGM presentation. There's the toolkit link in this PowerPoint deck right there. There's the training video from Abbott. And I think actually the updated slide deck that we have for you guys has a couple other links. It has the link to that review article I mentioned in it there. And then here is kind of the aggregated smart text to use. These are all fully functional in Epic now, thank goodness. But there's the RPM consent, there's the RPM enrollment ABS that has all of the coverage language. There's the RN initial visits, subsequent visits, the CGM interpretation note, and then your patient ABS. We also have some additional materials that are not in this deck for patients. So there's a patient FAQ, there's another brochure for patients about what is CGM. So, you might consider having a bunch of that at the front desk or something, if you have patients that want paper, or, posting it, maybe in the exam rooms. That's another way to just kind of market the new program. So I don't think I'm going to do a demo because we're short on time and I want to get you guys out on time, but we do have just a few minutes for more questions if you have any questions for me.
I want to just share my experience because I was watching Dr. Subramanian lecture actually about the CGM. So this is outstanding. So just use this 1 hour as a semi-opportunity for yourself and get you familiar with that, because the CGM is not something like a future right now, it's a presence. And that's the way how we're going to proceed the care with the diabetes in the next few years. Probably it will be more wider, spread out, and that's going to be the standard of care at some point. So we better be equipped at the beginning, and that's my best message, that it's not something new, something that you can brush out as a pilot. This is actually the reality, and that's how we are going to provide the care pretty soon, and it's going to be a standard of care. So take the time to watch this presentation on the YouTube, because that's outstanding. I watched this presentation live in May, I believe, last year. That's when she did first time. Yes. So, and this is outstanding. She's showing multiple clinical cases, and that's very helpful to actually dive into the problem. Probably more helpful than any conferences. So
That's good praise. We'll pass that along to Savita. I think I also just want to mention that Abbott and other companies are marketing the heck out of this. I know I just prescribed one for a patient I just diagnosed with type 2 diabetes, and she was like, oh yeah, I've seen like 17 commercials for that. So, you know, there's a lot out in society, and frankly, patients are, you know, demanding these types of technologies now because, you know, that's just the age that we live in. We gotta pick up new skills sometimes in medicine. All right, guys, thank you so much for your attention. Mika will follow up this with an email that's got a bunch of resources and also has the recording to the session. It'll probably come out, you know, maybe later this afternoon or maybe early tomorrow because it takes a little while to process the recording. And in terms of go live, the RNs and RDs, I think were they trained this week? Allison, were they trained yesterday? Sometime this week?
Yes.
All right, and so the Epic tools are live. Your billers and coders are expecting these charges to start getting dropped. So, you know, you guys can really just go forth when your clinic is ready. You know, where there's no, you know, specific go live date or whatever, it's ready to go.
Right, so thank you so much. Thank you for both of you, and we'll make sure that we are rolling it out. Mika, may I ask you to keep the session up for the few more seconds?